Good afternoon, everyone, and welcome to this afternoon's session looking at the cardiovascular consequences of COVID. My name is Annemarie Docherty. I'm an intensive care consultant up in Edinburgh. And before COVID, my interests were in the use of routine healthcare data to improve outcomes for critically ill patients with cardiovascular disease. So before I introduce our speakers, I have some brief housekeeping to go over. So our speakers will each deliver a 25-minute presentation, and we'll then have 40 minutes for questions and a discussion with our panel. Please submit any questions through the question and answer button to the right of the video stream. Questions will be directed to the panel during the question and discussion section, but I would urge you to submit your questions at any time, so we'll be looking through these during the speaker presentations. You also have the option to upvote questions that are already there. If you would like to submit your questions anonymously, please type anonymous before your question. If not, please include your institution at the beginning of your question so that I can announce this with your name. We might not have time for all questions, but we will try to get through as many as possible. Please note that this session is being recorded and will be available on demand following the conference. And please use the conference hashtag COVID-19 conference to share your thoughts on Twitter. So, with no further ado, I'd like to invite our first speaker, Professor Susanna Price, who is a consultant cardiologist and intensivist based at the Brompton in London. Her areas of expertise include critical care cardiology, including extracorporeal support and adult congenital heart disease. She's an expert in echocardiography and the assessment and management of critically ill cardiothoracic patients. So she is perfectly poised to deliver this talk. Thanks very much, Susanna.
Okay, so can I just check first that you can see my slide and you can hear me okay? Fantastic. So thanks very much for attending. We've got two parts to this afternoon. I'm going to really focus on the critical care aspects of COVID and the management of these patients. I've got no disclosures or conflicts related to this talk or any other. So in this next 25 minutes, I'm going to talk a little bit about what we were expecting from a cardiovascular critical care viewpoint, and then actually what we saw and what we did, and I'll divide my talk really into the left heart and then the right heart. So casting our minds back to February, March this year, we knew that we had, from a cardiovascular critical care viewpoint, variably reported mortality. And we knew that one of the strongest associations with high mortality was cardiovascular disease. And we were expecting around a 50% mortality in our critical care patient population. And what came out of China very early on, and what we began to see from the first cases that were in Lombardy, were reports of acute myocarditis and cardiogenic shock. And this is a young patient from Guido Davazzi and his group in Pavia in Italy, where they've got, this is a left ventricle for those of you who don't do a lot of echocardiography. This patient is receiving a lot of inotropic support, so it's a significantly impaired ventricle. This is a bit of lung ultrasound, and you shouldn't really be able to see these vertical white lines. That's indicating interstitial edema. And this is the pleura here, and you can see this little bumpy subpleural inflammatory process going on there. So this patient was developing rapidly progressive cardiogenic shock and acute pneumonitis, and they did go on in these early days to undertake endomyocardial biopsy, and they saw some interstitial infiltration, and they indeed saw some interstitial virus. So we at the Royal Brompton were one of the 5 national hospitals providing a respiratory Ecmo service. And on this graph, you can see the 5 hospitals, and you can see April 2018, April 2019, and April 2020. So dark blue for 18, grey for 19, and lighter blue for 2020. And these were the number of referrals we received per month. And you can see there's a huge difference in 2020 compared with previous years. So we were expecting a lot of myocarditis, we were expecting a lot of cardiogenic shock, but we didn't see it. And this is one of a number of studies that looked at cardiac tissues from autopsies undertaken by specialist cardiovascular pathologists. And the minority of patients had multifocal lymphocytic myocarditis on biopsy. There was some right ventricular strain injury, which I'll come back to at the end. And the majority just had interstitial macrophages. And around about the same time as this was coming out, we as the cardiology community were watching with interest. There was emerging evidence that this is an endothelitis or an endothelial disease, And early studies looked at the endothelium in the kidney, in the liver, in the gut, and also in the heart, and showed this to be affected. This is a really nice paper by Peter Libby and Tom Lucia, published in the European Heart Journal. And in this, they discussed the potential mechanisms with an activated endothelial monolayer relating to myocardial dysfunction, related in particular to why might you get myocarditis, we'll see it, and then discussing the mechanisms for type 1 and type 2 myocardial infarction. And you're going to hear more about that from the second speaker. So there we were expecting to see myocarditis, and we didn't see a lot of it. We didn't see a lot of cardiogenic shock, but we did see a lot of myocardial injury. This is a very early paper published in the beginning of March from Wuhan in China, numerous papers that came afterwards looking at cardiac biomarkers and showing that progressive elevation was associated with increased mortality. This is nothing new for the critical care community. We've known for many years, more than 20 years, that elevated cardiac biomarkers are associated with increased mortality in general intensive care and also cardiac intensive care. And the proposal back in June was that the myocardial injury seen in COVID-19 may have a phased response, so an initial ACE2 mediated direct damage, and then latterly a host inflammatory response or a SIRS type response, which we're used to seeing in critical care. On top of that, if there's superadded infection, there may be an infection related, maybe bacterial related or other myocardial dysfunction and sepsis that we've known about for many, many years. We've discussed and researched the potential mechanisms for the myocardial dysfunction seen in sepsis, severe sepsis, septic shock as it's evolved over the years, and associated with infection. There have been a number of papers published related to macro and microcirculatory disturbance. There's been no evidence of lack of oxygen delivery. There's been some discussion and some papers supporting dysenergetic use of oxygen, like we see in the peripheral circulation, and a number of studies and proponents of looking for circulating myocardial depressant factors. And actually that was what I did my PhD on way back many, many years ago. And in the myocardial dysfunction associated with sepsis, so this is the acute response, it's an imbalance potentially of a pro and anti-inflammatory process with associated cardiomyocyte hyporesponsiveness and also cardiomyocyte injury or damage. So that's the sort of background for what we would expect to see and what we do see. The general approach to a patient who presents with cardiogenic shock is firstly to address the underlying cause, because if you don't address the underlying cause, the chances are your patient isn't going to recover. And then in critical care terms, how do we optimize the cardiac output and cardiac index whilst maintaining a low venous pressure to ensure that the organs are adequately perfused whilst the heart recovers? So these are the sort of things that we look at. We look at optimization of heart rate with pacing if required. We don't generally address a sinus tachycardia. It's usually there for a reason. We do use inotropic agents for the lowest amount as we have as possible for a shorter amount of time as possible. And there's not much evidence supporting one agent over another. The literature isn't fantastic. If there's evidence of dysynchrony, we will address that if possible, and we'll do so acutely if we really need to. And there's always the balance between mean arterial pressure, aortic root pressure, ensuring coronary perfusion pressure is adequate, and in the patient presence of pulmonary hypertension or right ventricular dysfunction, that becomes particularly challenging. And I'll come back to that later. And if this doesn't improve, what we do is we escalate very early. And by escalate, we move towards using some kind of mechanical circulatory support to support the circulation. There are 4 main types that are available to us at the moment. The intra-aortic balloon pump has been around for a long, long time. It's inserted via the femoral artery, usually. It's about 30-35 centimetre long balloon, depending on how big a patient you're putting in. Is it pediatric? Is it adult? Is it a large adult? And it inflates and deflates in time with the cardiac cycle, intending to be inflated in diastole, deflated in systole, improve coronary perfusion, and reduce LV impedance ejection. The tandem heart is a device that's not much used. I'm not in this country anyway, so I'm not going to focus on that. And the 2 other devices that we use commonly or more commonly are the impeller. So the impeller is a device that goes in, usually again through the femoral artery, goes retrogradely across the aortic valve into the left ventricle, And it works on a kind of Archimedes screw type principle. And what it does is it continually delivers blood from the left ventricle into the ascending aorta. And Ecmo, which stands for extracorporeal membrane oxygenation, what that does is it drains blood from the right atrium of the patient. Outside the patient, it is then pumped through an oxygenator and it's returned to the descending aorta. So what that does is it provides the patient with peripheral flow and oxygenation, and it does maintain a low venous pressure. So this is a case that we saw I'd say about 6 weeks ago, a 42-year-old gentleman. He'd had COVID a few weeks before, and we were called because he was in extremis. He's in a different hospital from us, so we went with our Ecmo team. He was profoundly hypotensive, so he had a systolic of 65. He was tachycardic, around 135. His lactate was elevated, and he had a base excess of -7. And he was on escalating and bolus doses of inotropic support. So the way we assess these patients is we do two things. One is we use the SAVE score if we're considering using Ecmo. That's a reasonably well-validated score, but it works on a population basis rather than an individual patient basis. And we combine that with the SKY score, which you can see in this triangle at the top left here. So this is an A, B, C, D, E, so at risk of shock, beginning shock, classic cardiogenic shock, deteriorating shock, and then extremis. And extremis is a sort of patient where everybody's around the bedside, you're bolusing the drugs in, they may or may not have had a cardiac arrest. And this score has been reasonably well validated again for outcomes. So you can look at potentially how well your patient will do or not. And one of the biggest determinants in this patient population is also the age of the patient. So we have got a modified SKY score where we also include the age of the patient. So this patient is in extremis, so they're an E, and they are relatively young, so that they're in the amber. So they're this group of patients. So we would consider accepting these patients because they may benefit from extracorporeal support, but they have to meet all of the exceptional criteria. And why do we say that? We say that because if they don't, then they're not likely to benefit from this kind of very high intensity intervention. So no comorbidities, previously fit and well, that sort of thing. If there has been a cardiac arrest, we additionally incorporate the STOP criteria that we use for the CHEERS study for eCPR. So this is what it looks like with our patient. So you can see the venous drainage, the pump here, the oxygenator, and the return. And you can see also there's a little cannula coming here that makes sure that the leg is perfused and doesn't become ischemic. So now I'm going to show you what Ecmo actually does to the patient circulation. So here's a normal pressure volume loop. This is a patient with shock. And this is what's happened. This is a computer simulated model of shock when you institute your Ecmo at around 4 litres a minute. So what you can see is that the stroke volume reduces significantly and the end diastolic pressure and the diastolic pressures increase. So you're getting flow, but it's at the expense of the health of the ventricle. And why does this matter to us? Well, it matters to us because some of the early studies in VA Ecmo showed that the longer the patient is on Ecmo, the more myocardial necrosis and ischemia you see. And I'll come on to that in a little bit as to why. But part of it is that if you don't decompress your ventricle adequately and you have a very high left ventricular end diastolic pressure, you will see the following. You'll see this is pulmonary edema coming up the endotracheal tube. And assessing ischemia on a left ventricle that's on partial bypass is difficult, but this is mitral regurgitation that is extraordinarily long in duration. It's 886 milliseconds, and that's indicative of LV dysynchrony caused by ischemia. And here you see post-ejection shortening. So this is an ischemic ventricle that's not adequately decompressed. What can we do to reduce the end diastolic pressure and the diastolic pressures in the ventricle? Well, we can use inotropy, and we can reduce the mean arterial pressure, which you can see has been done here in green. And the other thing that we can do is to introduce the impeller. Remember, that's the retrograde microaxial device that ejects continuously into the ascending aorta. And the combination of impeller plus lowering the mean arterial pressure is a good one in terms of resolving left ventricular ischemia. So that's what we can do and did do in COVID when we did see catastrophic cardiogenic shock. But the trouble with using these devices are that they come at a cost, and the cost is mostly of complications. And the complications you can see here on the top left, it's relating to bleeding and thrombosis. On the bottom left, there's a high incidence of ischemia and limb damage. And on the right, you can see that there's issues related to the pumps. They're complex machines to use, although less complex than they were 20 years ago, and a risk of stroke and neurological damage. So what about that in COVID? We know COVID patients have are really challenging when it comes to hypercoagulability, and we are going to anticoagulate these patients quite aggressively. So is there any evidence that we can use VA Ecmo in patients with COVID? This is a study from the ELSO organization. It came out in September this year, 213 hospitals, 36 countries, over 1,000 patients included. And as we were expecting, very little in the way of myocarditis and acute heart failure compared with the predominantly ARDS cohort, a large number of super added infections, about 40%, and quite young patients, about 40 years, which you'd expect because they're the ones that have been selected because they're likely to benefit. Cumulative mortality is approaching 40%, which, considering how sick these patients, is extraordinarily good. But you can see that if the initial mode was VA Ecmo, it meant that they needed cardiac support, the outcomes were less good. What about using VA Ecmo in patients with septic cardiomyopathy or cardiogenic shock related to profound sepsis? This is the largest study that's been published to date. It is a retrospective study, and whether matched or not, you can see that the unadjusted or adjusted survival with Ecmo is significantly better. This is retrospective, of course, in patients with shock who are being managed with Ecmo. And these patients are really sick. You can see they've got an ejection fraction of around 17%, worse than the Ecmo group. They've got a cardiac index with septic shock of about 1.5, which is very, very low indeed. So these patients you would really expect not to survive, and albeit with a retrospective study, they did well. So what did we do with our patient? Well, we did put him on a VA Ecmo, and we also added in an impeller. He didn't need inotropic support. In fact, he needed dilators to drop his pressures. Now, one thing that can happen when you manage these patients with VA Ecmo, as the heart starts to recover and starts to eject, if the lungs have not recovered, what happens is the heart ejects deoxygenated blood into the ascending aorta, so-called Harlequin Syndrome or north-south, so that top of the patient's body may be blue and the bottom of the patient's body will be pink and well oxygenated. If you suddenly start seeing changes in your ECG, such as this, which happened to one of our patients on VA Ecmo, you would be suspicious that that is what had happened. And that's why we generally monitor from the right radial artery, not the left radial artery, but of course we can't generally get as proximal as we want to the coronaries. And if that happens, what we can do is one of two things. We can either take some of the oxygenated blood and deliver it back to the to the right atrium, so we're then putting oxygenated blood through the lungs, or we can completely decompress the right heart, profoundly lower the filling pressures, and then return these two venous drainage cannulae returns back to the descending aorta. So we either go VAV or VVA. There's no real evidence to support one over the other. And then, of course, every day we look to see if the heart is recovering. There are a few studies that suggest one or other modality may be superior. We use a combination of pulmonary capillary wedge pressure, basic echocardiography, and we're also now beginning to use strain and strain rate imaging to advise us as to whether the patient's likely to wean or not. So I'm just in the last few minutes of my talk going to turn to the right heart. We looked at myocardial perfusion in COVID-19, and we've got some data which we'll publish because it is different from patients with ARDS, and I'll show you some of our data later in this talk. We also assessed right ventricular function, and again, there are some important differences when it comes to comparing this bunch of critically ill patients with other patients who are critically ill with ARDS. So remembering how the right heart fails acutely, it's generally an increase in afterload plus ischemia that will cause your aortic flows to diminish. And on the left, you can see an early dog study which showed this absolutely beautifully. And we knew from fairly early on there was a high incidence of pulmonary embolism and thrombosis in our COVID patients. And in the ones we scanned at the Brompton, it's up to about 75–80% of our patients. We also know that positive pressure ventilation is not great for the right heart. So in the top here, this is an apical four-chamber view of a heart. This is the right ventricle here in a spontaneously breathing patient who's undergoing whole lung lavage for pulmonary alveolar proteinosis. And here the patient has been intubated and ventilated. It is not injurious ventilation. It's about 20 minutes later. And you can see the right heart is significantly dilated when compared with spontaneous ventilation. And these scans here show us that this is the longitudinal function of the right heart using a very simple echo modality, showing that ventilation reduces this. And also we can look at it using tissue Doppler imaging. Other things in critical care that affect the right heart. So the first thing that we do when we're ventilating a patient is we use positive end expiratory pressure. We ventilate the patient with positive pressure volumes. And if you look at how the right heart ejects, if you have a higher PEEP or a higher plateau pressure, if you have permissive hypercarbia and permissive hypoxia, you see this happen. So this is blood coming out of the pulmonary artery. And you can see that there's in pre-systole, so in diastole, you have forward flow. And this is because this ventricle is restricted, it's stiff, and associated with the things that we tend to use or allow in critical care, you may see significant restrictive RV physiology. That matters when your stroke volume coming out of your right heart is borderline, and during delivery of positive pressure ventilated breath, we will eliminate this, and you can significantly reduce your stroke volume by about a third. If you see a right heart that is dilating, here's a right heart, here you can see a lung that's completely destroyed. This is actually a patient with H1N1. We have other options that we can go for. So we can use inotropy, we can reduce afterload, or we can use mechanical support. One of the things that we found, so you can use all of these drugs to reduce pulmonary vascular resistance. Most commonly we use inhaled nitric oxide, but you can use all of these others. What we found in our COVID cohort was you could divide these patients into responders and non-responders. And the responders to inhaled nitric oxide had worse echo parameters for right ventricular strain. They had higher cardiac biomarkers and they were more profoundly hypoxic. And the other thing that we found, which was we haven't seen really before in any patients before COVID, was this pattern of right ventricular dysfunction. So unlike TAPSE, tricuspid annular plane systolic excursion, which almost every intensivist would talk about when they're talking about RV dysfunction, it was actually normal in the majority of our patients, as was the RVS prime on tissue Doppler. However, in our COVID-19 patients, there was a different pattern. There was definite evidence of right heart uncoupling in about 80% of our patients. It was severe in about 50% of our patients. The involvement of the right ventricle was radial, it was not longitudinal, and it was very, very dissimilar from other patients with ARDS. It's much more similar actually to patients who are adapting to pulmonary hypertension, and maybe we could have a discussion about that later. So just to conclude really, the cardiac involvement in critically ill COVID-19 patients is common and it can be severe, although to date, it's not been as severe or as common as we had thought it would be in terms of very severe and cardiogenic shock. In patients with COVID-19, mechanical circulatory support is probably safe and potentially life-saving, but in highly, highly selected patients. What we have noticed is that the right heart involvement differs significantly from that in other critical illness. So if you rely on traditional echo parameters in your critical care to determine whether your RV is affected or not, you're likely to miss it. And the longer term impact of COVID-19 on the heart is to date largely unknown, but I think we're going to hear a bit more about that in the next talk. So thank you very much for your attention, and I'm looking forward to hearing the next talk, and we'll take some questions later. Thank you.
Susanna, thank you very much. That's absolutely fascinating. I would very much encourage everyone to put their questions in the chat function, and then we can bring them up afterwards. So in the meantime, I'd very much like to introduce Professor John Greenwood. So he's a professor of cardiology, specialising in coronary intervention and cardiac MR imaging, and he's based in Leeds. His main area of interest is in the diagnosis and treatment of stable and unstable coronary artery disease. And in terms of diagnostics, this particularly involves the use of cardiac MR. So John, over to you. Thank you very much.
Good afternoon, everybody. My name is John Greenwood. I'm an academic cardiologist in Leeds, and I specialise in coronary intervention and cardiac magnetic resonance imaging. And I'm delighted to be invited to speak again at the Physiological Society and also the Intensive Care Society annual meeting. I've got no conflicts of interest for this presentation. And I think over the last day and a half, I think there's probably almost nobody in the country that isn't aware that coronavirus disease 2019 or COVID-19 is caused by the SARS-CoV-2 virus, and it's an acute respiratory illness that can progress to severe respiratory failure, as seen in the CT images showing acute respiratory distress syndrome. It also produces systemic inflammatory response syndrome in some patients, potentially a prothrombotic state. You can see here evidenced by pulmonary embolus. And importantly, it causes, in some patients, systemic or organ-specific complications. Many of these will be discussed throughout your conference, but I'm going to particularly focus on the cardiac-specific complications today. So I guess one of the first questions we want to ask is, does having chronic cardiovascular disease increase the risk of death in COVID-19? Now, this was a study by the Azaric 4C investigators and was a prospective observational cohort study of approximately 20,000 UK patients admitted to hospital with COVID-19. And what we can see very clearly is that in the top 10 most frequent symptoms reported was chest pain. But more interestingly, in this hospitalized group of patients, the comorbidities that patients were recorded as having very frequently included chronic cardiac disease and diabetes. And in fact, these were the two most common comorbidities reported, but also other important cardiovascular risk factors such as obesity, diabetes without complications, and smoking. And if we look at the forest plot on the right-hand side now, I think we can see some of the well-known features that are associated with increased mortality, that being increasing age, and you can see very clearly by the decile plots here on the forest plot. Also being of male sex was associated with increased mortality, but again, specific chronic organ systems diseases were also highly associated with increased mortality, and particular chronic cardiac disease. So clearly catching COVID-19 is bad if you had underlying cardiac disease, but is that the whole picture? Many of you who have worked in the health service will remember back in March and April the feeling of almost widespread panic as to what was about to happen in the UK, having seen the experience in Italy of hospitals being completely overwhelmed. And at that time, we were advised to reduce or almost stop completely all elective work so that we could make capacity in our bed base for what was predicted to be huge numbers of COVID-19 admissions. And this had some quite profound impacts on patients with chronic conditions. And you'll remember at the time the government's mantra was to stay at home, stay safe, and protect the NHS. And this combination of that action by the public, but also not undertaking elective work, meant that people were worried, and if not scared of coming into hospital if they were invited to come in for urgent appointments. And what we saw, if you look at this figure here, is the mortality by week in England and Wales. You can see the five-year average mortality in the dotted figure, and the numbers of COVID deaths on a weekly basis in blue. But quite clearly there is this increase in non-COVID-19 deaths that occurred in that period of March and April, which I think we need to look a little bit more closely into to try and understand what might have driven that. And I think these data that were published earlier on this year give us some fascinating insights into why that might be from a cardiac perspective. These are data from NYCOR that looked at admission rates to hospitals in England with acute coronary syndromes. And you can see very clearly at around that period of March, April, the number of acute presentations with acute coronary syndromes dramatically decreased. And also for the classic acute myocardial infarction presentations. And to a lesser degree, that was with the more severe ST elevation myocardial infarctions, who generally have severe crushing chest pain and end up bringing a paramedic ambulance. But what we saw was the biggest reductions was in the non-ST elevation myocardial infarction group, which is still associated with approximately a 10% annual mortality, even in those patients who are treated. So this gives us some reason to understand why perhaps increased non-COVID deaths occurred in that period, because patients weren't coming into hospital. And these two studies really just go on to emphasize that point. First of all, on the left-hand side, you can see that overall we were seeing less PCI procedures being performed for acute and emergency heart attacks. And what was really interesting was that although hospitals, when patients presented to them directly, were dealing with patients very efficiently, when patients needed transfer between hospitals, this was where the delays then started to have what was potentially an impact on patient outcomes. And the explanation for this probably lies somewhere in the fact that the ambulance services were being completely overwhelmed with COVID-19 admissions and queues at the emergency department, such that inter-hospital transfers were then delayed as a result. And if we look on the right-hand panel now, again, just to emphasize that point, what we saw was an excess of cardiovascular deaths in this time period occurring especially in the home environment rather than in the hospital. And if we look at some of the individual acute cardiovascular causes of death, such as stroke, acute coronary syndrome, acute heart failure, and pulmonary embolus, again, all of these increased at that time period of April and May as deaths occurring at home rather than in hospital. So if we turn our attention back to COVID-19 now, what we started to see in some of the very early reports is that there was perhaps evidence of acute cardiac injury in 30 to 40% of hospitalized cases. This was obviously quite concerning, and I think what we will do now is delve into that a little bit more closely to try and understand that further. So here are some data out of China in the very early part of 2020, the first 6 weeks. And what you can see in this study of 671 patients is that approximately 16% of them had evidence of myocardial injury, of which about 3/4 of those that did actually died. And if we look at the right-hand side of the slide, you see that the conventional measure of troponin I, a cardiac-specific biomarker, was very strongly associated with mortality if it was elevated above normal range. And in fact, if we look at the area under the curve for cardiac troponin at 0.92, you can see that this is actually a very powerful biomarker for in-hospital mortality. And what is interesting about these observational data, again from China, is that in those patients who survived, here in blue, the troponin tended to remain normal throughout the course of admission. But in those patients who died of COVID-19, often the troponin was normal at admission, followed by a slow rise as the patient disease severity progressed, to then an exponential rise as they became perhaps critically unwell and suffered complications, multi-organ complications of the COVID-19 infection. And this led some to suggest that in patients who have this small troponin rise, this may well represent either small type 1 myocardial infarctions, heart failure, PEs, or acute respiratory distress syndrome. But in those with much bigger troponin rises, this suggested that perhaps there was direct myocardial involvement, either from acute myocarditis, or they were having much larger type 1 myocardial infarction, so blockage of an epicardial coronary artery, or they were going into a phase of profound sepsis and septic shock. Now, as the infection spread around the world, other data became available from other countries, and the Italian experience was that approximately 10% of patients were dying with COVID-19 and had evidence of acute cardiac complications. Now, this led the NICE guidelines writing group to publish some urgent treatment recommendations back in April 2020, suggesting that physicians be aware that acute myocardial injuries in patients with COVID-19 could actually include quite a range of diagnoses, including acute coronary syndromes, arrhythmias, cardiac arrest, shock, cardiomyopathy, heart failure, acute myocarditis or pericarditis, and pericardial effusions. And on the basis of this range of potential complications, the suggestion was that caring physicians should be seeking cardiology advice early, particularly around further investigation and imaging tests. And this slide really just goes to show the complex interplay between all of the different mechanisms underlying acute inflammation and infection, and how this can express itself as a range of different phenotypes of myocardial injury, ranging through from endothelial dysfunction, plaque inflammation, instability and rupture, giving us the classic myocardial infarction type appearances, and acute coronary syndromes, through to direct involvement of the myocytes, with then a fulminant myocarditis leading to heart failure and arrhythmia. So how do we sort out what is actually going on in an individual patient with COVID-19 and raised cardiac biomarkers? Well, one of the things we can do is cardiac imaging, and you'll all be aware of the sort of workhorse imaging modality of transthoracic echocardiography. And this just gives us some really useful insights into left and right ventricular size and function, whether there's evidence of pericardial effusion, and also valve function. And here are some data from a multinational survey led by Mark Dweck from Edinburgh, involving approximately 1,200 patients from 69 countries. And what they showed was that from echocardiography, there were left ventricular and right ventricular abnormalities in more than 50% of COVID-19 patients. Now, this is obviously a observational study, which is has potential for bias, because these were selected patients who were going to have echocardiography on clinical grounds. But what they were able to show is that the use of echocardiography changed the management of those patients in over a third of them. So clearly an important clinical tool that we have, but actually it's still quite a crude tool and doesn't actually tell us what's going on at a myocardial level and what exactly is the nature of the myocardial injury. So perhaps a rhetorical question, but is echocardiography enough, or does cardiac MRI have a role? Well, what you can see here on the top right-hand panel is the use of late gadolinium enhancement MRI, whereby the normal myocardium looks very black, but areas of abnormal myocardium or fibrosis appear very white or increased signal intensity. And we can see that there are very different patterns to the type of myocardial injury depending on the underlying cause. In acute myocardial infarction, it starts off as a subendocardial wavefront, whereas in viral myocarditis, it tends to be much more mid-wall hyperenhancement rather than involving the endocardial border. And then there are other characteristic appearances in different types of cardiomyopathy. But interestingly, what we're also able to see very nicely with MRI is the actual pericardium itself. So we can see evidence of pericardial thickening in chronic or acute pericarditis, and also pericardial inflammation. Again, this white hyper-enhancing pericardium that's seen in acute pericarditis. So this is a very, very powerful tool, and in fact is now backed up by recommendations from the ESC and international expert recommendations, such that the use of CMR in myocarditis now gets a class 1 recommendation based on its ability really to tissue characterize and phenotype the exact underlying cause of damage. So let's look how this might be useful in practice. Here's an example of a 32-year-old male admitted with breathlessness and some intermittent chest pains, was COVID-19 positive, had a very small troponin rise of 150, but a completely normal echocardiogram and an angiogram that showed normal coronary arteries. And you can see from the 12-lead ECG that there's quite widespread T-wave inversion, which may lead you to wonder whether there's significant multivessel ischemia being present. You can certainly see from the cine MRI images down here that there's no evidence of a regional wall motion abnormality, so this patient would be reported as normal by transthoracic echocardiography. But when we move on to the late gadolinium enhancement images by MRI, we can see that mid-wall or sometimes subepicardial hyperenhancement that's absolutely classic of acute myocarditis. Again, here a bit more of a patchy distribution, seen mid-wall or epicardially. And when we look at different weightings on the image, particularly for increased water content or edema, inflammation, particularly on the T2 weighted images here in the interventricular septum, you can see again that there is an increase in the T2 weighting, again suggestive of acute inflammation, which matches up very nicely with the late gadolinium enhancement images. And here we see a different patient now, a 51-year-old male with diabetes, severe chest pain, again COVID positive, but this time with a much larger elevation in the cardiac troponin I. And the 12-lead ECG this time perhaps doesn't look quite so severe, but there is evidence of ST elevation in the lateral leads. And when we look at the cine images this time, you can see now there's quite a profound wall motion abnormality with akinesia in the lateral wall extending around into the inferior wall and also into the anterior wall. So a very marked regional wall motion abnormality. Now this time when we look at the MRI, it's absolutely classic with this subendocardial hyperenhancement that spreads out in a more transmural direction in certain zones of the myocardial, absolutely typical of a myocardial infarction and not something that you can misinterpret, for example, as another form of either cardiomyopathy or as acute myocarditis. And here we see the potential of cardiac MRI at an individual patient level. These are some images from UCL in London, and you can see that this unfortunate patient has got 4 different types of cardiovascular complication. First of all, having a thrombotic occlusion of one of the arteries, and you can see on the late gadolinium enhancement images evidence of extensive infarction in the inferior wall spreading to the lateral wall. There's also evidence of thrombus in the aorta and pulmonary embolus in the branches of the left pulmonary artery. But interestingly, on the late gadolinium enhancement images, you're also able to see in areas that aren't infarcted some more patchy mid-wall and subepicardial hyperenhancement, much more typical of a viral myocarditic picture. So a myocarditis, an acute infarction, an aortic thrombus and a pulmonary embolus all in an individual patient, all fully phenotyped by one single imaging test. So let's have a look now at some of the very limited data around cardiac MRI. And perhaps not surprisingly, the earliest studies came out from China. And this was a study of 26 patients who'd recovered from hospitalized COVID-19. They tended to be young with no comorbidities and were actually all troponin negative. But interestingly, this group of patients were suffering with ongoing cardiac symptoms after discharge. And in this patient cohort, about 58% of the CMR scans were claimed to be abnormal, with about 54% showing evidence of acute edema in the myocardium and about 31% suggestive of hyperenhancement on late gadolinium enhancement imaging. Now, these are some much more compelling data from the Royal Free in London, and they looked at patients discharged with COVID-19 and evidence of myocardial injury as indicated by an elevated high sensitivity troponin. And in 51 patients who underwent cardiac MRI, and in those who had an elevated troponin of unknown etiology, what they were able to show is that about a third of them had evidence of non-ischemic scar on the late gadolinium enhancement images, i.e. a myocarditic picture. Only 5 of the 29 had evidence of ischemic damage or myocardial infarction on its own. 4 of them had dual pathology, so a mixture of ischemic scar and myocarditis. And in about a third of patients, there was nothing that could be elucidated from the MRI scan. And perhaps this is suggestive of patients who had more severe sepsis, hypoxia, hypotension, in which case it was more likely to be a type 2 event rather than direct myocardial involvement either from the virus or from from the infarction. Now, the last paper I wanted to touch on is the largest MRI series from Frankfurt, which looked at 100 patients who'd recently recovered from COVID-19, of which only a third had ever been admitted to hospital. And they originally made a staggering claim that approximately 78% of patients had myocardial or pericardial abnormalities based on a single MRI scan. And not surprisingly, this created an internet sensation with huge amounts of tweets and an incredibly high altmetric score. But unfortunately, there were a lot of controversies around the way that the data were presented, such that the paper was essentially completely reanalyzed and resubmitted. And suggesting that these levels of abnormality were not perhaps quite as high, particularly when you took into account some of the upper limits of normal based on figures that they were claiming. And also, one of the big limitations of this paper is that the control groups, the healthy controls and the risk factor matched controls, perhaps don't appear to come from a contemporary set of patient data, and perhaps not even patients that were scanned on the same scanner in the same institution. So this makes it very difficult to tease out what some of these findings mean. And I think what the community has been left with from this publication is a lot more questions perhaps than answers. So in order to try and understand how COVID-19 affected the heart, back in April of 2020, the British Society of Cardiovascular MR set about establishing a national research consortium to apply for funding from the Department of Health and Social Care as part of the COVID-19 Rapid Response Rolling Call. And within 4 weeks of submitting an application, we had a funding decision which was thankfully very favourable. And what we wanted to do was focus on a hospitalised recovering patient population who'd had evidence of raised cardiac biomarkers or troponin. And we wanted to really focus on 3 main aspects to understand the mechanisms. First of all, we wanted to know what the true prevalence was of acute myocardial injury and myocarditis secondary to COVID-19 as diagnosed by the reference standard imaging technique of CMR. And then we wanted to try and understand how does cardiac involvement and the clinical outcomes associate with the known risk factors for mortality, such as age, sex, ethnicity, and cardiovascular comorbidities, and how does the genetics interplay with these known risk factors. And then finally, what we wanted to do was look at patients with acute myocarditis and see specifically if there are differences in myocardial recovery at 6 months months, dependent on their demographics, genetics and comorbidities, and how that impacts on their reported quality of life measures and their functional capacity as measured by a 6-minute walk test. So the key thing to this study, which will be unique, is that they'll be having an MRI scan during their index admission when they're acutely unwell but recovering, but they'll be having then a convalescent scan at 6 months, and we'll be able to see how that recovery and repair process has evolved and the things that impact on that healing process. So where are we in terms of progress? Well, what would normally take us about 12 months to develop a protocol, a database, get regulatory approval and individual hospital approval around the UK, we've managed to achieve in about 3 months, and we've now got 22 centres open with another 5 in red that are hopefully going to come online very, very soon. And as of the 13th of December, you can see that we've now got 87 of our planned target 330 patients that we originally wanted. Now, it may be that we've been very conservative on our sample size and power calculation in that the levels of abnormality that we're seeing in this population that we're studying seems to be much greater than was first thought. However, we are aware that the recruitment window, according to this 12-month funding stream, closes at the end of January, and we've got obviously still quite a long way to go to that timeline, and a lot of patients still to recruit. And that perhaps leads me on very nicely to the next question. We've been through the second wave, and the question I think a lot of people are asking, is there going to be a third wave? And these are some data that I took off the internet on Sunday night. This shows you the local authority areas in England with the reported daily cases per million population. And what you can see in just about every local authority, the rates are increasing. All of these local authorities, bar 2, are red. And what we're seeing now is that despite a month of national lockdown in November, which did have some positive impact, the numbers across the whole of England are now dramatically increasing. More centres will be going into Tier 3. London's just entered Tier 3. And I think once the impact of the 5 days of celebrations of Christmas is over, we're going to really see some profound problems, I think, towards the middle and end of January. And I suspect the hospital caseload will again rise quite dramatically. So that's obviously very disappointing from a public health and an NHS perspective, but hopefully will enable us to be able to reach our target recruitment figures. So in conclusion, we've certainly seen that rates of hospitalisation and mortality from COVID-19 is much higher in patients with cardiovascular disease. And we've also seen that troponin is an extremely good prognostic marker acutely, associated with a 5 times increase in mortality if elevated. But importantly, we need to understand that there are multiple etiologies to a raised cardiac troponin, and CMR is potentially of huge value in these symptomatic patients in being able to look at the etiology of the troponin elevation. But what we don't want to do is scare people and think that CMR is a useful test in asymptomatic convalescent patients, because I think the data just doesn't support the use of that at all, despite what's been reported in some media sources. And finally, what we really need is some high quality research so that we can understand particularly around cardiac recovery after COVID-19, and also the influence of genetics, cardiovascular risk factors, comorbidities on the heart's recovery, but also their impact on patient function and quality of life. And on that note, I'd like to thank you for your attention and take any questions.
John, that was superb. Thank you very much. I'd like to invite all our panellists to come back and introduce Dr. Anna Batchelor, who is a consultant anaesthetist and intensivist in Newcastle upon Tyne. So she needs no introduction to many of us, as she is a past president of the Intensive Care Society, also past dean of the Faculty of Intensive Care Medicine, and indeed a past member of the Royal College of Anaesthetists. So thank you all very much. I think there we are, we've got Susanna as well. There's a number of questions that are coming up in the chat. I just wonder if I could take the chair prerogative and ask Susanna and John if they think that this is any different from H1N1, or is this something that we would see with any severe acute respiratory infection?
So John, shall I do the acute thing and then you can talk about the longer term? So definitely what we're seeing in the hearts of these patients is different from H1N1. In H1N1, as I showed you, the mechanism and the extent of the right ventricular dysfunction is really different. And in the first wave of COVID-19, it was interesting, we saw almost no left ventricular involvement. It was very unusual. And what we did see was subclinical. You would only detect it if you're using things like global longitudinal strain. And that is similar to usual sort of ARDS and H1N1. The right heart, though, is very, very different. Something seems to be different in the second wave of COVID-19. We're seeing more patients presenting 2-3 weeks after their initial infection. They seem to have got better, and then they present with dyspnea and cough, very similar to the patient that I presented. And we're seeing profound biventricular dysfunction. But interestingly, it gets better really pretty quickly in terms of clinically better enough to get them off extracorporeal support and off intensive care. What it means down the line, I don't think we have any idea.
Yeah, I just follow that up from an imaging perspective. I think what we are seeing is more myocardial involvement, I think, from this virus than other viruses that we've dealt with in the past. Whether that's because patients are sicker or more of them are in hospital and we've just got more patients to evaluate by some of our advanced imaging techniques. And I think we're also seeing this multi-morbidity sort of impact on the heart, whereby it's not just either myocarditis or infarction, it's combinations of multiple impacts on the heart, whether it's due to the prothrombotic state and the ongoing direct myocardial involvement as well from the virus. So I think there are multiple things all playing in together at the same time. And I think what we really don't know from some of the MRI studies is the sort of how this will play out in the longer term, and the impact that pre-existing cardiovascular disease will have, in the impact that genetic susceptibility might have, how that might work across different ethnic groups across the UK, for example. So that, I think there's a huge amount of questions that we just don't know the answer to at the moment. And I think it'll be really interesting to see not just the acute imaging effects, but also the convalescent imaging effects and how the heart recovers from this. We may find ultimately that in a number of these patients who've had severe multi-organ involvement, that the hearts don't fully recover, and that then leaves us a potential substrate for increased numbers of patients with heart failure and arrhythmia problems to deal with, particularly when you think of the numbers of people across the UK that have been impacted by this virus. It only needs a very small percentage to actually have heart involvement for that to suddenly mount into the thousands of patients potentially that we'll see through our clinics in hospital.
And can I just add to that, there is data from the first SARS epidemic suggesting that patients' lipid handling is abnormal for up to 12 years afterwards. And we know from other pneumonia reported events that patients' cardiovascular disease risk is increased for about 10 years, up to 10 years afterwards. So you've got a combination of comorbidities, more involvement of the heart, and then these other things that we know from other pneumonias, plus from the previous epidemic of the MERS, or the first SARS epidemic, that it does bad things to your lipid handling. So I think it'd be unlikely that cardiologists aren't going to see some impact from this, really.
Yeah, I agree. And I think one of the unique things about this virus is just the sheer volume of patients that are coming into hospital, whereas with previous flu episodes on an annual basis or other novel respiratory viruses, each individual hospital may only have one or two patients over a sort of winter period that was significant and severe enough to require sort of either ICU support or cross-sectional imaging like we're able to do. And what we're seeing now is in any one individual hospital, tens or hundreds of patients. And so it's actually quite easy to study this virus, I guess, in much more detail than we've ever been able to study viral myocarditis in the past.
I was interested, Susanna, you saying that the presentation of patients in the first wave is very different from the second wave, with the right ventricle and then biventricular. Can you think of any reasons why we're seeing that difference?
I think that there's a lot of discussion about differences. The one big difference is patients are having different treatment when they come into hospital right up front now. So the way they're given volume is different, the way they're given steroids, whereas before they weren't. So we're not seeing the same patients that are untreated in the same way. By the time they get to critical care, they've been managed totally differently compared with in the first wave. So that would be one thing. I mean, then the other thing is also, why was it that they saw a lot of myocarditis in China and they didn't in Italy? Is there a population difference? Is it a genetic susceptibility? Is it a population difference, or is it the virus has changed? And I think we don't know.
Anna, are you seeing differences in the units with patients presenting? So between the first and second waves?
Sorry, did you ask me?
Sorry, it is, yes. As in, are you seeing differences on the unit?
Right. Having sat out the first wave, I wouldn't be able to comment. And interestingly, we don't seem to be seeing, I think it's because we don't look for it properly, much in the way of cardiovascular dysfunction. We've all kind of done our training in basic echo. And from what Susanna was saying, I'm wondering whether we need extra training in order to be looking at these patients, because the very simple things that we all learn to look for, you know, is it full, is it working, things like that. There's quite a lot of differences here. And even when we see right ventricular dysfunction, we can't say, oh yeah, I presume this patient's had a PE, let's start treating that, because there's so much else happening here. So we've kind of taught ourselves and been taught to use something which isn't always as helpful as it might be. And I'd be really interested to know what Suzanne and John think about that, because they're the tools that we've got. If I was to ring up the radiology department and say, can I have a cardiac MR? Yeah, I can think what the answer is, and it's quite short. It's not going to happen, is it? Apart from in a research study.
I think that's one for you, John.
Yeah, well, I mean, it is difficult. I mean, Echo is the workhorse tool, which we all use every single day, and it's easy, quick, portable, and gives us some very useful acute information, but it really doesn't sort of tell us what's going on at a myocardial level. So we actually have a very low threshold for doing cardiac MR in these sorts of patients. Even before COVID-19, patients came in with indeterminate chest pain, perhaps a slightly dodgy looking ECG and a troponin rise, but didn't have what was thought to be a classic acute coronary syndrome. We would always want to MRI these patients, and it is part of the ESC guidelines now for patients who come in with an acute coronary syndrome and have unobstructed coronary arteries to have MRI within 2 weeks. That's a class 1 recommendation. Now, clearly that's a challenge for many units around the country and the world to provide that, but certainly the bigger academic centres are able to do that. We love doing cardiac MRI. We've got 3 dedicated MRI scanners in the cardiology department, so we're just waiting for all those patients to be referred for us, irrespective of whether it's a research or an NHS patient. So, and it's the same, I think it would be the same probably in Edinburgh and in many of the big London centres and things as well. So it is there available. It's a bit more challenging if you want to do it in an ICU patient who's ventilated, There are some studies that have been done in ventilated patients, and I know the Leicester group are coordinating an application at the moment to look at doing cardiac MRI in ventilated patients. I think that'll be a particularly challenging group to study, but would certainly give us some interesting insights as to the physiology that's going on in that setting, particularly around the right heart as well. So it is possible to do, but I accept that only a handful of patients will get this imaging test. But that doesn't mean to say the results of what we're able to show doesn't have some more generalizable implications to a wider patient group.
Mm-hmm. And so, I'll answering the first bit about should everybody be learning more echo. I think to be able to do it really well and for it to be really meaningful, it's what you have to be doing all the time. And if you think it's difficult to do the sort of more basic echo techniques, to be able to do some of these more advanced echo techniques in a completely reproducible way that you can actually make a call on is very, very challenging. And it's very attractive because you get a nice display and you get nice numbers. But when you sort of look under the bonnet, as it were, and you look at the quality of the scans that are being done, the interpretation of them, it's a really high-end expertise. So I was very lucky through the first wave of the pandemic to be working with a consultant colleague who's a real expert in perfusion echocardiography and strain echocardiography, and we were able to combine that with very in-depth physiological echo, which allowed us to take a really, really close look at these hearts. But it's not easy, and I think if you're going to do it, you need to do it well, and you need people who are really, really well trained to do it.
I follow up on that. Do you think then the flip side is actually that we should be calling in our cardiology colleagues earlier in patients who have a seemingly normal echo?
So, I mean, I work in a unit where we're an Ecmo unit, so the patients we're getting are the sickest patients. So, it's slightly different. However, we image every patient that comes in. They get a CT, they get a recruitment CT, they get a CT of their brain, they get a CTPA, and they have an echocardiogram. And if we can't get adequate images with TTE, we may use contrast, or we will do a transesophageal echo if there's no contraindication. And if anything changes or there's any question about the clinical status of the patient, they get another echo. And our echo service is primarily in the ICU is cardiologists, but cardiologists that are embedded in the unit. I guess if it was you who was sick or your relative who was sick, who would you want to have a look at the heart if they're catastrophically sick? That's the question. And I think the difficulty with COVID-19 is what the sort of historical echo markers of RV dysfunction at a basic level are quite easy to measure. And now we're saying with these patients, they're not helpful. So you can be misguided and think that the heart is actually okay, and actually it's not okay. And it's not okay in a way. So when you looked at some of the uncoupling, it's not just oh, well, that's interesting, isn't it? We were seeing these patients had more hepatic congestion as measured by their hepatic enzymes. So I think it's not, and they had a higher BNP, they had higher troponin, and you would have said that was completely normal using standard echocardiography. So I think it's complex, it's a new disease, and we don't understand it yet, so we don't know how to assess it. And some of the parameters we've used before don't seem to be valid, so we can be lulled into a false sense of security.
The nice thing about MRI is that it can also be done when the patient's either recovered or even when they've gone home, and it can still give us some very useful information. Yes, it's not going to guide the sort of acute management when they're on the unit or on the coronary care and things like that, but it can certainly answer the longer term questions. So with the patient who's had a significant troponin elevation, it's very different to whether you want to institute long-term secondary prevention, so antiplatelet agents, statins, ACE inhibitors, all these other things, because it's been a type 1 MI and the implications that has for the patient, or whether it's been a touch of viral myocarditis, which actually doesn't need any of those. So certainly doesn't need the sort of platelet agents, things like that. So making that definitive diagnosis using a tool like MRI does actually change quite profoundly the patient long-term management. And we get lots and lots of patients now referred who've come in acutely, was it an acute coronary syndrome? Was it myocarditis, pericarditis? And the only test that really can answer that is an MRI test. And so we get bucket loads of patients either referred for an inpatient MRI before they go home, or an MRI in the first few weeks after discharge to try and make that definitive decision for them.
That actually feeds in very nicely to one of the questions asked, which says, even taking into account the limitations of the Puntman study, how closely should we be monitoring recovered patients for cardiac abnormalities? And what would be the easiest and also most cost-effective measure, i.e. what variable to be chosen to analyse those who may be susceptible?
I mean, I think from my perspective, if they're asymptomatic and recovered, I wouldn't worry or do anything particularly. But if they've got ongoing symptoms, then you do, particularly if it's sort of ongoing cardiac symptoms, breathlessness, it could be lung damage, it could be cardiac involvement. We're now getting lots of referrals through of convalescent patients who've got ongoing breathlessness symptoms. Is it a heart failure? Has it been sort of fulminant myocarditis? Are there other causes? Is it a pericardial problem, etc., etc.? Is it an occult infarction? So those are the patients that we'd be quite interested to image. And I think, especially if they've been in hospital and had a raised troponin, if they've been in the community, then obviously you probably won't know what the troponin is. And for most of the clinical scenarios, the first test you always do is a simple echocardiogram as a useful screen out test. And if the left and right heart look completely normal on echo, then I would only really want to progress to MRI if I've really got evidence that there's been some cardiac damage from a biomarker test.
Thank you. Now, there are also a couple of physiology questions, which I will definitely pass forwards rather than attempt to answer myself. What happens to the baroreflex sensitivity in patients with COVID-19, even in those with little cardiac dysfunction? Are neural pathways affected?
So I'm going to say I don't know, I'm afraid. From an acute critical care viewpoint, I'm afraid I don't know.
Thank you very much.
Great question.
Whoever asked that question could answer it as well. That would teach us all. We could try this one as well, possibly. Do we know how the cardiac pericytes contribute to the acute heart injury by COVID-19, since they have the highest expression of ACE2? Is it causing reduced myocardial supply due to the damage of the microvasculature?
Again, I think it's difficult to tease that one out from an imaging perspective. I mean, there are so many causes of type 2 MI, whether it's sepsis, inflammation, hypotension, shock. It's difficult to say what the exact causes of these sort of type 2 MIs. And often, as I think I showed on one of the cases, in these type 2 events, you often don't see anything abnormal about the heart. So although there's been a troponin release, and it can be considerable, it's not due to the direct myocardial involvement. It's more due to ischemia, whether that's been a sort of subtle low-grade continuous insult or an acute insult. So the actual myocardium itself may not look impacted, but that doesn't mean to say that there hasn't been, as I say, some evidence of strain or ischemia on the heart at the time.
That's a fantastic question. So acutely, we don't know. We do know that in patients with cardiogenic shock who receive extracorporeal support, if you look at the microvasculature recovery and alongside with the cardiac recovery, the microvasculature recovers first. So you can see recovery of the peripheral microvasculature way before you see recovery of the heart. And with the very high expression of ACE2 in the pericytes and their role in control of the microvasculature in the heart, I think it would be it's a very interesting hypothesis. Quite how we go about proving it in the critically ill patients, I think is very, very difficult.
Yes, certainly. So we've not seen a big signal for patients on ACE inhibitors either way in the historic data set. And whether that's just because there isn't a signal or whether there's just so much confounding, it's impossible to pull out, the patients who are sicker and the selection bias as to who gets those ACE inhibitors. Is that your experience, John?
Yeah, I mean, for the data that I've seen, I don't think ACE inhibitors or A2 receptor blockers are advocated or advised against in either way. The data seems to be sort of this equipoise around them, as far as I understand it. So the recommendations are to continue therapies for patients who are on those agents.
So I have many other questions, but Anna, do you have any questions that you have?
Yeah, I was wondering if I could ask some hugely practical things for the sort of ordinary intensivists out in the real world. So I know that we've discussed previously about the funding for VA ECMO in heart failure, and you clearly are providing some of this. If people have somebody that they want to get to that service, do they call a conventional ECMO service, or is it only offered in particular places? Because most people are going for VV ECMO because of respiratory failure, aren't they?
Yeah, and some of the patients, obviously the team turn up and there's profound myocardial involvement, and then we have a discussion as to what to do. That's a really difficult question to answer, Anna, because obviously in a time where the health service is really, really pushed, we should be reaching for evidence-based therapies and not be using non-evidence-based and non-funded therapies. That said, it's very difficult if you have a 28-year-old with severe acute respiratory failure that meets the criteria for VV, but they actually need some cardiac support as well. It's very difficult to say, well, because you've got heart involvement, we're not going to fix you. There is no funding for VA ECMO. It's a non-commissioned service. It's done on a case-by-case basis, depending on how likely the patient is to benefit from it. It carries with it very high risks to the patient, but so you have to be very clear with the family and the relatives what your expectations are. Not every centre at all offers it. I know that post-cardiotomy, of course, our cardiac centres do offer usually central VA ECMO or percutaneous right and or left-sided support. There's been discussions as to whether people who are doing VA should stop doing VA for the duration of the pandemic. But as I say, it's difficult if somebody is sick with COVID-19 and their heart doesn't work and they're young and you know it's probably going to get better. It's very difficult to say no. So we run a service and we're building a network whereby we were asked some time ago by the commissioners to look at what it would look like if we were to build a network based on the existing geography for the national VEV service. So we've been working on that and developing a retrieval team and criteria and data and expanding our perfusionists and our nurses and our whole retrieval capacity. And we work very closely with Guy's and St Thomas's for that. I know that the other ECMO centres do it, but they do it, again, it's not funded, so they do it on an ad hoc basis. Usually the calls will come in through the VV ECMO service, but they may come in through, depending on how the service is set up, either interventional cardiology, or they may come through the cardiac surgeons, depending on who's really leading the service. I do think that we're getting to a point where I think the commissioners need to look at it because people are doing some kinds of mechanical support anyway. And I would much rather that it all happened under the basis of a trial rather than ad hoc and piecemeal across the country. So that's what we're advocating for.
Thank you. And the other thing that I'd really like to talk to you both about, because clearly you are kind of building this evidence base at the moment, is I think post critical care follow-up and rehabilitation input is it's really come to the fore with COVID because there are so many people out there who are needing it. And at the moment, most of those people are going to a clinic led by respiratory physicians, some intensivists, some rehab people, a lot of involvement from physio, other allied health professionals. But I'm not really hearing much about input from cardiology as part of that system. Is that something that needs to start getting planned in, or is it something that people just should get referred off to afterwards? And I wondered what the cardiology world was thinking about that.
Yeah, you're probably right. I don't think, I'm not aware of cardiologists being sort of directly involved in any of those rehabilitation type services and long COVID type clinics and things like that, but clearly there's a potential role, and as I'm sure that as we pointed out, there are potentials for long-term cardiac involvement and potential for increased incidence of heart failure. It's how best to, I guess, tap into the appropriate sort of expertise in the cases that need it, rather than a sort of blanket approach to everybody. Otherwise, we'll just have patients seeing half a dozen different services and different specialists, and they'll get sort of hospital or sort of health service fatigue sort of type thing. So I think it's so easy to get an echocardiogram, and it's so easy to look at the patients whose echoes are not normal and really focus, I guess, most of our attention on that group of patients, perhaps in the recovered group, rather than perhaps worrying so much about everybody who's got a normal heart, who might just have a little bit of post-viral sort of edema or something like that. It's really the ones where the ventricle's impacted, I think, from a functional level. I suspect from many viral episodes, if we looked at the flu virus in detail, for example, I suspect many people who had a bad viral illness would have episodes or evidence of myocardial edema, myocardial inflammation at a very subtle level, but it may not have any longer term implications other than just there's a bit of a convalescent and recovery phase associated with that. So I think we just need to focus probably from a cardiology perspective on those with functional problems.
So just and adding to that, and if a patient gets so sick they end up on our ICU and they've got a heart that's not normal, we would routinely discuss them with our heart failure team. So they'll get plugged into a standard follow-up through that. Tim Evans set up post-crit care follow-up at the Brompton, gosh, it must be 30 plus years ago. And following on from, and usually that is, the usual multidisciplinary team that run that. But following on from COVID, we have actually got great interest from our heart failure team. So they are called if there is an issue, if the patient's symptomatic. And then the other thing that we're using is I think if we allow these patients to go home that have comorbidities that are not addressed, that's a massive missed opportunity for primary prevention. So I think taking account of what people's lipid status is, what their cardiovascular risk is, what their lifestyle is, given the comorbidities that are associated with increased mortality, I think that should be something that we should be addressing. It's a bit like somebody comes in with a myocardial infarct as an index. That's the time to make sure they're getting the evidence-based therapies, because getting them back is really, really difficult. So I think that's where we probably should be focusing our attention now. Good primary prevention in patients with risk factors that are not addressed.
I'd love to think that's happening, but I'm not sure it is.
I'm sure it isn't, and it's a shame because it's a great missed opportunity. But I think everybody's so stretched doing what they're doing. Yeah. And as John alluded to, the reorganization of cardiac services was so profound, not just in this country, but actually right across Europe, that people have been really scattered to the winds. They're learning new ways of following up patients, and then to introduce a whole new cohort in that context is very challenging.
Yeah. One of the things that was very clear doing the GIRF project, looking at critical care, is how both our speakers work in centres of excellence where they have access to things that people in many DGHs can't even dream of. So we do need to have some clear messages that we can send out to people to say, right, this group of your patients that you're worried about, this is where you should be channeling your concerns, because yes, we don't want to overwhelm cardiology or radiology or any other services, but it'd be really useful, wouldn't it, to have a kind of post-COVID cardiac guideline. These are patients that you should be referring on. These are the things that could be offered, and everybody sign up to that, because often pushed services will push back and say, actually, we're too busy. We're still trying to catch up on the heart failures from the heart attacks that people were having in spring that we didn't treat. we're all pushed.
And I suppose so that feeds in very nicely to the long-term impact of COVID on patients who didn't get COVID, and all the elective cardiac surgery and cardiac procedures that haven't been able to take place.
Yeah, the collateral damage is not insignificant, I think. I mean, the data from across the world is compelling, and the rescheduling of cardiac surgical patients that's had to take place absolutely everywhere. And the other problem is that patients, as John said, that, you know, they're scared. They're scared to go out. They're scared to go to hospital. They don't want to come in and have their procedures. And they are still, even if you provide them as safe a pathway as you can, they're still reluctant to do it. And so there is, with the patients that we're seeing coming through, are sicker than they would be otherwise because they've had their cardiac surgery in particular delayed. So their pulmonary hypertension is that bit worse. Their left ventricular function is worse than it was. And the patients who had their surgery in the first wave were those who absolutely couldn't wait. They were all risk rate, RAG rated, and those who were emergencies, urgent, and had to be done were done. But everybody else was put on hold largely.
I think to recover from that sort of suspension of services across the board is going to take us years probably to get back to where we were. I mean, I think we're looking at probably a year or two to catch up. I saw some figures the other day just looking at patients with aortic stenosis who either didn't get their surgical valve replacement or their TAVI, and I think there was something like potentially a reduction of I think it was 1,200 cases that were missed or not performed as would have been expected in that 6-month period around the sort of first wave. So that's a huge burden of patients that have got to come back through the system, irrespective of all the new patients that are coming through with aortic stenosis. And that's just one cardiac condition, which has a huge sort of impact on mortality, let alone all the other things that we've not picked up, all the coronary disease, the heart failure, all the rhythm problems, etc., etc. So it's going to take us ages to recover from this, irrespective of all the new COVID work that might start to creep through as well.
It's just really simple stuff. Patients waiting for other operations have not been out walking, they're getting less fit, they're presenting for surgery, and they're not going to do so well. They're going to get more complications because they've not had their prehabilitation, all of that. The whole thing is a mess, isn't it? We're really going to struggle for a long time. I agree totally.
So I think that's a sobering message to bring this session to an end with. Does anyone want one last word?
Yeah, I'll, if I may, anybody who's listening here who has a relative, a friend who has cardiovascular disease and they're getting unwell, please tell them that if they need to be seen, they need to be seen, and don't delay, don't sit at home, get yourself to hospital. So symptoms of chest pain, they think they may be having a heart attack, they think they may be having a stroke, don't sit at home. This is what you should be telling your friends and relatives. If you're sick and you think it's your heart or cardiovascular and you think it's an emergency, then get yourself to hospital. There are safe pathways there now.
Okay, thank you, Susanna. And thank you to all three of our panel, I think, for an excellent session. I am duty bound to let people know that there's a satellite meeting called COVID-19 and Mental Health, exploring the impact on academics, which is following on from this at 5 o'clock on a separate Zoom meeting, to which you should have been sent an invitation. And come back for day 3 tomorrow, beginning at 2 o'clock with the neurological session. So thank you very much once again, and a superb session. Thank you.
Okay.